Hey everyone, it's Samantha Busch and you're listening to Certified Oversharer. Today we are going to talk some things infertility and IVF, and I'm going to get right into how this convo started. So yeah, I'm not name dropping, I'm place dropping. I was at the White House. Very cool. I got invited to this women's luncheon at the White House. I don't even know how some things in my life happened to me, but lo and behold, there I was. So the White House was creating this group of like women senators and different people, and they invited other women to be there that were part of different groups. So like I believe we got invited because of the Bundle of Joy Fund. There was different groups of mothers that were there for like schooling reasons. Savannah Chrisley was there. Now I am name dropping because that was really cool. Anyways, introduced myself to all these people, and we're all kind of like swapping stories of why we're here and what our organizations do and like what our goals were. Like there were some women from Maha there, and they were talking about just what public school system lunches look like and how they wanted to change that. And there were women there that was just talking about all sorts of stuff. It was very fascinating. With all that being said, though, I went up and introduced myself to this lady, and she was part of this group. And so I told her that I was part of the Bundle of Joy Fund, and instantly she was like, "Oh, one of those groups." And I was like, "What? Like, I help, but we help pay for people that can't afford IVF. Like, what do you mean?" And she's like, IVF, like you guys just make snowflake babies and then throw them away whenever you want. And I was like, wow. And I kind of like went mama bear mode, and I was like, excuse me? Like, what do you mean by that? And she was like, well, if you don't know. And I'm like, okay, lady, like if you don't know, but please talk. And she's like, well, if you don't know, they basically like make all of these babies at will, and then they get to decide what they look like just, so they can have these perfect babies, and then they freeze them, and then they just throw them away when they're done. And I was like, as a mother of two IVF children that actually, had to do multiple egg retrievals and who's experienced multiple miscarriages and who had to use a gestational carrier to have her second child, that is not at all what this process is like. And so then, she goes, well, if I had struggled that much, I would have just adopted. Okay, wait, so I have to back up. Before I even answered her, I asked her, I said, did you struggle with fertility? And it was kind of one of these like, no, like, why would I? And I was like, okay, well, I started it like a little mama bear, but like educational too. And I was like, okay, like, let me explain to you what the process actually is. And like, I'm trying to explain to her how there's male factor and there's female factor and there's unexplained infertility and how all these things happen and why people have to go through this and the cost of it. And as I'm like going through this and trying to just give her more of like the landscape and the scientific facts, she literally just goes, if it was that much of a bother, you should have just adopted. And I was like, what the is like what I really wanted to say, but I'm in the White House, so I'm trying to keep my together. And I was like, okay, I'm going to be the bigger person here. So I was like, well, ma'am, like what would your approach be to somebody who cannot have children on their own? Because in case you didn't know, infertility is a disease. So what would you suggest people do? And she was like, well, they have to take out one egg at a time. And I was like, okay, do you know that each egg does not guarantee an embryo? And she just kind of looked at me. And I was like, this is the misinformation that is out there that drives me crazy. So as somebody who has PCOS, I make a lot of eggs, but that doesn't mean they're good eggs. So when I did my own egg retrieval, I got 31 eggs the first time. Like Kyle and I, totally naive, we were like, whoa, we're going to make so many embryos. And then all of a sudden it's like, you have 15, you have 12, you have 8, you have this, you have that. For most people, like if you get 1 or 2 or 3 embryos, like that's amazing. And just because you have an embryo and just because you even do genetic testing, there is still no guarantee for a healthy baby. As somebody who's gone through 6 rounds, and when I tell you, like on paper, I was so ideal. Like our first round transfer, we had Brexton, everything went great. So when we went to go have our second transfer, they were like, oh, your embryo looks wonderful. It was genetically tested. It turns out perfect. You had a successful pregnancy, therefore we're not worried about you. Miscarriage, failed cycle, gestational carrier failed cycle, another miscarriage, had to go back to gestational carrier. So like nobody can tell you just because you have these embryos that it's going to result in a pregnancy. I mean, think about this. This is wild. We had embryos that at one point didn't take in me and didn't take in a completely separate woman. So like there's no guarantee. And so this is what's really hard for me when people have these flippant comments of like, they just have to take one egg at a time. Okay, if you've never been through an egg retrieval, the cost, the medication, mental, physical, you name it, like there's so much that goes into that. What, like, are you going to have a woman endure that 30 times to maybe get some embryos? Like, it's just not logical. Now, I think that there are practices. I think that we're going to talk to the doctor. Are there more conservative ways that you can approach it? Yes. But it really pisses me off. And I get DMs like this too a lot. And it really annoys me of like, you know, you just did IVF so that you could choose the sex of your baby. Hey, guess what? I had to go through a second egg retrieval. And the second time, we only got all girls. So like, it's not like I was like, okay, I would like you to make this one a boy and this one a girl. Like, you can't decide that stuff. And so I think I want to have this conversation today because is it great that infertility and IVF is more mainstream and more in the media? Yes. But I think that there's a lot of people and a lot of groups out there that know maybe like a teeny tiny percent of it, and then they twist it into something else that kind of fits what they think it is. And so today, no bias, right? No anything. We're going to bring a reproductive endocrinologist on. His name is Dr. McCoy. He's part of the Preg Clinic. They are a clinic that the Bundle of Joy Fund helps. And we're going to ask him some of these questions. We're going to ask him, what are the limitations of genetic testing? And, you know, what are the ethics surrounding it? Are there things that you can do if you're like, hey, I am very nervous that we're going to make extra embryos? Or like, statistically, how many embryos do most people make? What does that fall off look like? I think that there's just a lot of questions out there that instead of people going to a really reputable source, they're like, oh, well, I saw this on the internet, or, oh, I believe this, so I'm going to start spreading that as truth. And so that's where we're going to go today. We're going to get an in-depth discussion on all things infertility and IVF from an actual reproductive endocrinologist, not just people that are looking for clickbait or who have their own ideas and opinions on things that they have no idea what they're talking about. Let's be honest, some of my best stories start with, so I had a drink, and spiral from there, which is exactly why Big Rack Spirits feels like the unofficial sponsor of every unfiltered moment on this podcast. Whether it's the East Coast Cooler, Trailblazing Tangerine, or Rosie's Pink Lemonade, they make flavored vodka that goes down easier than your latest situationship. It's all natural, super smooth, and honestly, dangerous in the best way. No fake flavors, no mixers needed. Just pour, sip, and overshare. And maybe cry, obnoxiously laugh, definitely regret saying it all out loud. But hey, at least it was entertaining. Oh, and they're not just out here making delicious chaos in a bottle. Big Rack gives back too. Military charities, breast cancer foundations, real impact with every pour. So if you're gonna tell on yourself, you might as well do it with a drink that's worth it. Must be 21 or older, please drink responsibly. Today, I'm super excited. We have Dr. McCoy on from Preg, the clinic that the Bundle of Joy Fund works with. So I'm honored to have you here because a lot of my social is all about infertility, and to have a reproductive endocrinologist sitting right here to ask all the questions to, we are so excited to have you on. So thank you for coming.
Well, I am so excited to be here. I love to just share the information and wealth of knowledge. I was like, oh, this is something I got to make happen. So
tell everybody, what's a little bit of your background and specialties?
So a reproductive endocrinologist who specializes in fertility, we all come through an OBGYN background. So we go through 4 years of medical school, 4 years of OBGYN residency, then it's a 3-year fellowship, which is pretty competitive. There aren't a lot of us. When I came through training, there was only about 34 in the country each year. And so we go through a 3-year training there to basically, our specialty is in the reproductive hormones, both male and female, reproductive surgery aspects, plus things like infertility, things like in vitro fertilization and just the gamut of infertility. And then each of us kind of branch out a little bit. I've done more fibroid removals than most people ever in the country. But I've also subspecialized over the years in male fertility. It's often overlooked a little bit in our field. We all get a little bit of training, but not a lot. And so I started doing that out of necessity in my first job, and it's just evolved. And now the guys are about 30% of my practice, and I love it.
Well, that was going to be my question. So if you look at it statistically, 1/3 of the time it's male factor, 1/3 of the time female factor, 1/3 of the time unexplained, which we need to get into that 'cause I hate unexplained infertility more than anything. But do you think because in the past it's always looked at that fertility is just something for women, that it quote unquote couldn't be the man's fault? So is that why it was so maybe not as brought up when you were going through all your training?
Well, it's really pretty equally male and female, though those are the classic numbers, the third. Really male stuff, in my view, is more around 40% of the issues we see. And the incidence of male issues is almost as common as the incidence of female issues. And there's just a lot of reasons. It's for a lot of reasons, some on the guy side of just not wanting to get investigated, and that's a frustration in and of itself. But yeah, in our field, because we come down in OBGYN training, it's somewhat one-sided. We worked with male urologists, fertility specialists in training, but a lot of people don't really take that interest, and they just look at it, okay, I have this sperm count and this is what I do with it. We do intercourse or inseminations or needs in vitro. And we'll talk about this more. I'm always a fixer. I'm like, first, let's see, is there anything we can do about it? And a lot of times I can alter things. If you can fix it, why not? And so I like the male side to try to really maximize it. And I think the male psychological aspect is overlooked. The impact that it has on males, obviously, the impact it has on the females. And, guys sometimes aren't as sharing. We don't make podcasts about our feelings.
Ladies, let your husbands listen to this if they have sperm issues.
Yeah.
Here's a good question, and this is something that I was reading, is that over the past couple of decades, the rise in male infertility is increasing. Their sperm counts are going down. Now, I won't lie, I'm like it's our environment, it's our food, all that type stuff. Do you think that plays into it?
I don't disagree with that at all. No, there's multiple factors.
Are you a secret conspiracy theorist like I am?
Depending on what we're talking about.
Okay. This could be fun.
No, I think a lot of it, we know there's a big relationship of male fertility and obesity. There's a big relationship to toxins. One of my biggest issues we were talking about, I practice in Nashville. There's a lot of alcohol intake, and alcohol can be a big issue. And so there are a lot of those non-healthy type lifestyles. A lot of it's inherent that a lot of guys are born with these problems, but there are a lot that I think it does come from some of these environmental and poor diet. Do
you think like the preservatives and the artificial stuff in our food causes it on both the male and female side?
The hard part, it's so hard to prove and study that. I mean, because like even with the sperm counts, those studies, because what people don't understand, sperm counts vary just ridiculous amounts from day to day. You can go a sample today and a sample tomorrow, and it'll vary by 50 to 75%. So a guy might have 30 million sperm today and have 80 million tomorrow. And he might have 30 million today and 5 million tomorrow. So when I look at a count, I always say, I don't know if this is you on a good day or a bad day. And when there's just that much variability, it's hard to see a real defined trend.
Oh, that's interesting. I didn't know that.
A lot of the studies would say, okay, cut out whatever, and then we'll recheck an analysis. Well, the overlap is so enormous. You really would need about 4 to 5 analyses to really figure out the average, and then go back and make an intervention and do 4 or 5 more. And most studies have never done that much. So that's why it's kind of fraught with problems trying to figure out. I don't think, so much of this stuff, preservatives and stuff like that, I think there's no way it's good for us.
Right.
Absolutely. It's just, it's hard to prove anything. And
that it's a direct cause.
Right. Because the same way with the eggs, the eggs, that only a fraction of eggs can make a pregnancy. Humans are not good reproducers, I always say. And it's just hard to study. We don't have a specific test except taking bunches of eggs and seeing the outcome of them. And even then, in an IVF setting, the variation day to day is tremendous. You can do the exact same thing 1 month and the next month and get just tremendously different outcomes doing nothing differently. It's just really frustrating. And because of that, that's why it's hard to study.
Well, that makes sense. I mean, I guess, so my question was like globally, or I guess in America. So I was listening to the Joe Rogan podcast the other day, and he had Kash Patel on, and they had said that there was like a researcher. Did you hear about this? In Michigan. Okay. And he was some sort of like agricultural scientist or whatever. So he brought some like, please, if you want to hear more, like actually go to the podcast because I'm probably going to butcher this, but like some spore or something over. And like he could have used that to put into our wheat and our corn and all this. And it was directly targeting fertility and reproduction. And how, like, do you see this becoming like an American, what's it called, epidemic, that like our fertility is so bad? Like, what does that look like 100 years from now for us?
Well, I think it's also hard to definitely there's more recognition of it. All of us had the family members of my aunt who just couldn't have kids, and we all had those. And so a lot of times it wasn't brought to the surface, which I'm glad we have. But yeah, so much has changed just in our diet in general, and a lot for the good. My grandparents were raised on the farmer diet, but yeah, they all died of heart disease at 55, so much, but it was a cleaner food too. And, and you do worry about, some of the conspiracy stuff, and I'm sure it's not conspiracy, is that, we grow whatever it is, tomatoes, or I've got a little garden too, like,
yes.
And I'm struggling with my garden, but whatever, these are breeds of tomatoes. Like, I'm growing tomatoes, but these are breeds that have been selectively genetically bred over the years. And it's so far away from what an original tomato was,
I didn't even think about that.
Yeah, because it's bred under, so you go buy seeds, but that's all you have access to.
Right.
And farmers plant, there's only a couple strains of corn planted, and those have been bred to be, large crops and, water resistant and bug resistant and stuff. And so you wonder, that if that has had subtle changes
over the last couple of decades.
Yeah. I mean, but by far, I think obesity is the biggest issue.
I was going to say, that's what I was going to ask.
In general. And some of the new medications have been a godsend for some of our patients because it is so hard. Patients struggle with weight, especially patients even in general, but PCOS we can talk about. But that's been a big godsend change for that.
Is there anything, so I did tell people that a reproductive endocrinologist was coming on the show. And so they did ask, a couple of things were diet and lifestyle. So I think we talked about, we just talked about BMI, we talked about alcohol. Is there any certain foods, like anything that people should consume? I mean, obviously a healthy Mediterranean type diet, like I feel like we all know that, but is there anything that sticks out to you that you're like, if you're trying to maybe increase your sperm count, or things that you should avoid or maybe should eat more of, is there anything like that? I
think on both sides, it's the stuff we all know. We all know we need to eat healthier. This is the doing it. That is the thing. But definitely the one of the big things with both male and female, and just that links to obesity, is just the making a minor role in the carbs. Carbs are good, but carbs are bad. And trying to really minimize that and having a well-rounded diet. So things like a Mediterranean diet, and a lot of those, there's not one that's specifically better than another, but the one mainstay about any of the good diets is a very low percentage of carbs, and that's what really fuels the obesity, insulin resistance, and that's a big issue in both sides, on male and female. So if I could tell people anything, it's doing that. And most of them, if honestly they stuck to a big diet like that, the weight will follow.
That makes sense. Now, when it comes to supplements, like I'm a huge supplements person, and I'm also studying to do infertility coaching. And so one of the studies that we were just reading is that in Australia, they found that women who paired an IVF cycle with melatonin saw a 40% increase in success. Do you have any background on that?
Don't know on that specifically. And supplements, is a field. I tell patients, always be careful, because someone wants to always sell you something.
Okay.
And patients are very...
Well, you'll try anything because you want a baby.
Absolutely. They're in a situation that I tell people, if I told them to stand on their head 3 hours a day, they would do it.
I mean, we might have tried that, trying to have a baby.
And we want, so my main idea is I try to, the only thing we have to go by is scientific data, and it's hard to come by. And supplements, just because, like we said, studying natural fertility, it's very difficult to show any. There's only a couple that have some theory. For things like this, hypotheses to work, there has to be at least some scientific theory behind it. And there are some people that want to do stuff because it just keeps them busy and feels like they're doing things. And I think that's fine. I think it has a good placebo effect. Things like melatonin, you wonder, are they sleeping better?
Well, so I was wondering.
Or something, because, the stress can definitely affect things. And when people are stressed, they often aren't sleeping well. So things like that, you wonder if it's, but the hard part is differentiating, between it, to study it. That's the real frustration. So, I tell people that, primarily it's being a good, healthy diet. We all want a simple, easy fix, but it's just not like that. You don't have that. If we did, we wouldn't be having these conversations. And there's a couple supplements here and there that have a little bit of evidence.
What supplements would you say for male or females? Like, is there anything that, like, in your clinic that when people are going through IVF that, like, it's part of their protocol?
First and foremost is eliminating the toxins. And these are the things that people don't want to do, cleaning up their diet. On both male and female, alcohol have a big impact. And I'm not I don't want to throw people under the bus and be super strict about it. But we know, like on guys, there's great data that having more than 10 drinks a week has a massive impact on sperm. More than 5 drinks a week, you start to see it. So I tell guys, really, you need to limit it to less than 5 drinks. And what I find is, most guys are either only having 1 or 2 drinks, so they're fine just to quit all the time, or they're in the problem area and they struggle with that.
Gotcha.
But that we think that effect washes out in a couple months.
So first and foremost, people need to be looking at their lifestyle under a true lens.
That's by far the easiest thing to do. But way before you take anything else is quit taking some stuff. I think that's number one. Alcohol is big. Smoking, obviously is huge. And luckily we're seeing less and less of that. But older studies showed on the female side, smoking decreased female fertility by 1/3.
Wow.
And I'm like, there is nothing you can do worse than that of hurting your smoking. And unfortunately, you do see a lot of, mostly in the younger population, of vaping.
I was just going to ask if that has the same effect.
We've recently looked into it, and the problem is with vaping, you don't know what chemicals are in that. You buy this stuff and you don't know what's in it. But there's the glycerin products. These are stuff that are not good to inhale. And we know that any gases that you inhale in your lungs crosses straight through the bloodstream, crosses into the ovaries. You can find like nicotine in the ovaries. And so vaping, studies are hard to look at it, but we've recently looked at this, that we consider it just as bad as smoking. That it seems like on both the male and the female side, it has an impact.
That's really interesting. I'm going to switch gears on you from diet and lifestyle, because obviously IVF, infertility, all that has been all over the media, right? And I feel like, yes, good. People are finally talking about infertility and recognizing that as a disease and all this stuff. But with it getting so much information out there, there's also a lot of misinformation.
Oh, yeah, my everyday is.
So tell me, with this media explosion of infertility, what are you guys seeing at the clinic level, at the doctor level? Like, how has that affected you?
There's the good and the bad of the social media. I think in the past, so much of the kind of weird, crazy stuff was people trying to sell something, and then now you're just getting some straight up social media bad information of some crazy stuff. People will bring stuff to me and I'm like, okay, that's a new one. I haven't heard that.
Tell us, like, what is it?
Oh, no, it can be anything. And it's just like, what? And it's just my jaw will drop. But I think, there are still a lot of snake oil peddlers in our world, and that's bad.
Like, there's just so many misconceptions around IVF, and obviously, like, I've dealt with it, given that we're very public about going through IVF. And one of the things that I got, and I've seen a lot of, is, people, if they can, they're just making quote unquote like designer babies. Can you talk about, so like we did genetic testing because obviously we wanted to try to avoid a miscarriage. Did not work for us, but we were told, if you do the genetic testing, we're able to tell you which embryos likely could implant and could result in a healthy pregnancy. And so we were like, oh, okay, this will be a road that we need to go down. did not work. But talk to me a little bit about the field of genetic testing, why it's either good for patients to do or not, and what those misconceptions are. Because I think like people are like, oh, well, you could just pick out a blonde hair, blue-eyed boy and he'll be 6 feet tall
So
and
easy.
this, and that. And I'm like, that's not
how it works.
not how that's happening.
How any of that works.
So explain to people who might not know why you guys use genetic testing and what are the limitations or capabilities of it.
Well, when IVF got started and in the infantile stages in the 90s, it was very, it was not very successful. Implantation rates, per embryo would be in the 15-20% range. So we often transferred multiple embryos, hoping to get a pregnancy. Sometimes you got burned with multiples, which weren't healthy. And so, but a lot of it we didn't understand. And then we come to learn that a lot of those embryos were not genetically normal. And that's normal in humans. Humans are not good reproducers. I tell people we don't have litters for a reason, and it's a small fraction. The best case scenario of a 23-year-old peak human fertility is about 1 out of 3 eggs could make a pregnancy. By 30, it's 1 out of 4 or 5. By 35, it's 1 out of 7, 8. By 40, it's about 1 out of 10 or 12. And that's normal. That's on a good day. And there's a bell curve distribution on either side of that. And the number one reason is because you'll have an egg and a sperm that come together and it miscombines. And the reason it changes with age is that almost all the machinery that allows an egg and a sperm to come together, most of that comes from the egg. And so, guys make sperm till we die, but women are born with all the eggs they'll have. And so that machinery becomes somewhat defective with aging, starting in the 30s. And so the percentage of embryos that ultimately end up being genetically normal declines with age. And the problem is embryos that are genetically normal and genetically abnormal can look identical. Sometimes the ones that are perfect, beautiful textbook pictures can be horribly abnormal and have zero chance of being viable. And sometimes the ones that work are the ones that are very mediocre looking. So you can't judge by looking at them. So that's how we used to do it. Initially, we used to transfer embryos on the 3rd day because we couldn't grow them to the 5th day. The 5th and 6th day is as long as we can keep them outside the uterus. They attach around day 5, 6.5. And so letting them grow to that 6 days serves as a selection process where they self-sort themselves out. The ones that don't make it to that point are uniformly just terribly abnormal genetically. But just because they get to the blastocyst stage, just because they get there does not mean they're normal, but their odds of being normal is way better than you started. Mm-hmm. And so then we would just pick the one that was prettiest, kind of symmetric and fit the textbook description. And when you have a group of embryos, the one that's the prettiest, if you compare the prettiest one to the ugliest one, the odds of the prettiest one having a higher chance is a little higher, but it's not absolute. And so then genetic testing came along, and it was really in its infancy in the early 2000s, and it was fraught with a lot of problems, but it's gotten way better. I mean, it's even in 10 years, we've made advancements massively. So every year it's just getting better. There's been a recent tier just in the last 2 years that's better than it was 3 or 4 years ago, or when you had gone through. So it's several levels beyond that. And the main idea of genetic testing, you can't make the embryos be anything. They've already been programmed. The minute they start to divide, they're programmed. But what you can do is when you have a batch of embryos, you can sort out which ones are the good ones and which ones are not. So the main purpose of genetic testing, and it's not necessarily right for everybody, but it is very helpful, is it shows you the good ones and gets you to the good ones faster. So, every study shows it gets you to the good ones faster. And so that's one of the biggest purposes. When you look at it on an age-based relationship, that is very helpful as a woman gets older because the percentage of embryos are lower that are normal. And so that is really helpful. Because I always say, say we had 5 embryos, and out of those 5 embryos, statistically, 2 of them are good. If I go through and transfer them one at a time, I'm going to get to the good ones just the same. But you're likely going to have to go through some transfers that are going to fail. Right,
which is financially, emotionally, physically.
And the emotional aspect and the financial aspect. Whereas if you can weed those out and show you the 2 good ones, you can expedite your time there.
Which I think is important because each transfer costs, what,
$3,500?
Yeah, $3,000-$4,000.
Yeah, I mean, it's the cheaper part of IVF, but it still adds up.
Yes. So if you're going through 3 or 4 rounds while you're trying to get to the one that might make it, well, now you're at $12,000 just like that. And so I think that's what a lot of people don't understand either.
It has a little less benefit the younger a person gets, but there are some scenarios like, of course, if they carry a genetic disease, we do that every day. You can test to make sure that embryos are not affected. Some are interested in it to know the sexes because you do get the sex. About 50% of my patients want to know the sex for their first embryo. And some don't, some do. But I tell them when they come back for baby number 2, every one of them wants to know.
Oh, yeah.
Yeah, so
well,
absolutely.
It's funny. People judged us so much for that. And I'm like, okay, if you had the option to know, and they're like, well, you just chose what you wanted. I'm like, well, no, we had a boy and a girl. Yeah. So like, yeah, with that information, like, of course we were going to do something. Like,
and sometimes I'll have patients have me randomly pick, and it's semi-random because there is some thought process, because I know a lot of people might want a balanced family. So if I have somebody maybe in their first transfer and they've got 1 boy and 3 girls, I will probably start with a girl just because we're still learning things about her. And, so sometimes I will semi-randomly pick too. But very few people actually come to us saying, I want a boy. There are some, but it's usually the people that they've had 3 girls and they want a boy, or vice versa. They can help expedite that.
And I also try to tell people too, you don't always get one of each sex.
You cannot make them be anything.
Right. You can't do that. So I think that's what people thought. I think people, when they hear it, they're like, oh, well, you did IVF so you could have a boy and a girl. And I was like, that's not how that happened.
That's Kyle's issue.
Yeah. Okay, that's a sperm issue.
Sperm determines the sex. Well, though most guys have a combination of both sperm.
Well, and I just think that's so fascinating. And like, just to debunk those myths, you cannot pick if your baby's going to have blue eyes or brown eyes or anything like that. You can't choose their hair color.
There are, in the pipelines, the genetics are there's been some statements recently put out about doing those kind of things, because that technically probably isn't too far down the line of it being possible.
But now that I find crazy.
But there is so many more important things, right? Because that makes it sound like all these embryos are good and all of these are going to make a baby and I'll pick this one. No, it's like, I'm happy to get a baby out of it.
Well, yes. Or even like for us, a lot of our embryos were graded and some were graded okay, but there was only a couple that they were like, these are the ones that we think have the best chance. And then what I try to tell people is, so we had Rex in our first round, everything was great. Statistically, they told me, and this might sound high given my thing, but because our next embryo was graded really well, because I had a very healthy pregnancy in the first try, we had something of like upwards of an 80% chance of success. Does that sound accurate?
Depends how many embryos. Our gold standard in the US and world runs for a genetically normal embryo, runs about 65% per embryo.
So they were saying because my embryo was really good quality and because I had carried
that's a big plus, because, when a woman comes in, it's been unproven, you don't really know, but that is a plus.
Yeah. So I try to tell people like, I actually talked to an embryologist once at our clinic at Reach, and I had been there. We had gone through a miscarriage and then we had gone through a failed cycle, and I happened to be there giving away a grant. And I thought this was so cool for like a scientist to say. Basically, I was like, why is this happening? Like, why, if my embryos are so good and I'm so healthy? And he goes, because we could do all that we can, but at the end of the day, God's choosing.
Right.
And that has stuck with me for forever, especially like a guy who, you just think like there's so science, everything's science. And he was
we can only do so much.
He's like, I can only do so much. Yeah. And so,
even in our best case scenario, a third of the embryos don't work when everything's perfect.
Right.
And it's frustrating to not be able to explain those to patients. And I think a lot of it is when I see patients, my biggest thing is I like to educate patients. You sit down with me and a new patient visit will be an hour, but I can tell you in 5 minutes what you should do. But it's for me trying to get the patients to understand things like unexplained. What does that mean? And I try to educate them so that they, not just me tell them what to do, but they understand why I'm doing that. And so I like to, preface things and say, hey, this is the expected, these little follicles you see don't all yield eggs. People count the follicles and I'm like, no, I say, we don't have the eggs till my embryologist has the eggs.
Right.
And then I explain the horribly depressing drop off to fertilization, to embryo, to genetically normal embryo, to pregnancies. And so a lot of times the guys, especially, their jaw will drop when I tell them we want 15, 16 eggs. And they're like, oh my gosh. And I'm like,
we had 31.
I'm like, oh no, it takes that many. Sometimes it doesn't, but sometimes it does. And you don't know. But yeah, the genetic testing helps to show us the good ones faster. You get a slight reduction in miscarriage rate, but even then, the gold standard right now is we're still seeing a 10 to 14% miscarriage rate of genetically normal embryos, and that's hard to explain. Some of that might be the outer cells that turn into the placenta could be somewhat defective. Of course, there can be a uterine side in some people, but it's hard to know because when I drop off an embryo inside a uterus to that 12 to 14 days to a pregnancy test, that's an eternity in this 5-day embryo's life.
Right.
And it's hard to know what didn't work. But you have to, it's not helpful to patients to just say, I know sometimes it just doesn't work, but that is some of the truth of it. And I think that there are a lot of things that's not in mine and your hands.
And that leads me into the next thing. So I think one of the big misconceptions, and I'm not going to say got in a fight with a lady about this, but I'm going to say we had a very strong disagreement about this. She obviously had never been through infertility or anything, and she told me that it was wrong of me to make, quote, snowflake babies. That's what she was calling them. And I said, well, what would you do? And she said, well, you need to take out one egg each time and have one sperm, and do one at a time instead of these, she called them these batches that we just throw away. And I was like, okay, lady, first, let me explain to you that I saw this quote when all this stuff was going on with IVF and embryos and all that with Alabama. Nobody loves and cares about their embryos more than the parents. That is so much to us. And so I think when other people talk about it so flippantly, it's very hard for me. And I was trying to explain to this lady that each month, IVF, I had read somewhere, I think it was through Cooper Surgical, that IVF, and with the amount of embryos that you get, it almost over time mimics natural, what a natural pregnancy would be. Because a woman gets a period, right? And she might be trying, but it doesn't result in a pregnancy. Correct. Same as grabbing that egg, they took 31 eggs out of me. When it was all said and done, we were almost down to 5 embryos. So it drops off. So can you explain to people out there who maybe are completely unfamiliar with IVF why it does not make any logical sense to go in and take one egg each time?
Yeah. Well, IVF, we use it for lots of different reasons, and we still have to work with what you bring us. We can take out variables. We're eliminating variables. We're bypassing the fallopian tubes. We can help the sperm fertilize if they would otherwise have issues. But so much of IVF is successful through numbers because, again, humans are bad reproducers. And, the potential of each egg making a pregnancy on average might be around less than 10%. And even women who are maybe naturally trialing their own don't think they're not probably fertilizing eggs on their own, in behind. You don't know that, but they probably are. And then so many natural eggs die. I mean, a woman loses 1,000 eggs a month just in the natural death process.
For real?
Yeah. And so when one of the questions I get asked often, is are we using up all my eggs? Are we burning all my eggs up? And I'm like, oh Lord, no. We are rescuing eggs. We're saving the eggs that were going to die that month anyway. And so about 1,000 eggs a month on average, die the natural death. So we're saving eggs. And I tell people my goal is never to make embryos that nobody wants to use, but we're trying to achieve a goal here. On average of people, you hear about people talking about excess embryos. On average, though, it's about 15% of our IVF patients will actually have excess embryos, which means 85% of them either wish they had more or had the right amount. And so it's pretty uncommon. There are situations usually with younger women who can make better eggs and, that can have extras, but most of them don't have extras and we wish we had more.
Yeah. And so what I was trying to explain to this lady is if you were taking out one egg at a time, the amount of medications, what that would do to your body, and then you'd have to do.
There are situations where people have tried that, but the utility of it is horrible. Both, logistically and financially. Something not quite to that extreme, but it's done. I believe it's in Italy. They're not allowed to freeze embryos. Oh. And basically anything that fertilizes, they have to transfer it back. So they will often go and only retrieve 2 or 3 eggs at a time, or only retrieve more and only fertilize a couple because they're forced to use them.
That's so interesting.
Yeah, I think that's the closest to that. And then there are always some charlatans in the U.S. that do these kind of natural cycle IVF, which is really a way to drain your bank account painfully slowly
Why?
over time.
Well, first I want to back up. So if Italy doesn't do any frozen transfers and they're only doing fresh,
I'm pretty sure that's been in the law in the past. Yeah.
what is their success rate compared to America to like bring home a healthy baby?
Well, and I don't think they do genetic testing there, and the gamble and trade off is probably by, like we used to be, doing excess embryos, transferring day 3 embryos, and we would put 2 or 3 back at a time, and you hoped for the best and then hope you didn't get burned. The goal is always to make, we always say building families one baby at a time is our slogan. But yeah, it's hard, but the utility is very low, and the mental anguish and the physical, emotional toil of doing a retrieval. I mean, retrieval is an easy process, but it's not a benign process. I'm putting a really big needle into your abdominal cavity, and that has some risk associated with it.
Well, and all
so
the
to do that every
medications.
month for, likely the odds on each individual month, if you do it 1 egg at a time, it's probably going to be in the 5% range, if that. And so could you do that? Oh, sure. But it just makes kind of no sense. But I always do. Part of that is when couples come to me, I say, tell me, and I'm usually looking at the woman hiding the guy's face. I'm like, tell me, in a perfect world, how many kids would you like to have? Because I have some that say we just want 1, and I have some that say I want 7. And so that will be a different goal. A woman that really only strictly wants 1, well, no, maybe we don't need 20 eggs. And we have some ways to mitigate that too. So nowadays, because we can do egg freezing, I'll have some people that want to be real strict. We will make a line, and I'll say, okay, in general, it might take me fertilizing 7 eggs to make 1 pregnancy. So we might do that. We might harvest 15 eggs, freeze 8 of them, fertilize 6 or 7, and just make 1 embryo at a time. And I say this is probably not the most efficient way to go about it, but if that's what works for you,
I love that that you guys offer that. If I'm being honest, I hadn't heard about that, and that makes a lot of sense for people who don't want to have that fear of having excess embryos.
Right, because that's a tough decision, I'm sure.
Yes, and having to decide
what to do with them. And, I tell patients, when they come to me, tell me that, and we'll kind of work with that. And I have a lot of people that say, oh, we don't want to do IVF. I hear that a lot. And I try to explore that. I was like, well, stop right there. I'm like, well, first, just tell me the whys. Mm-hmm. And a lot of it revolves around that. And I think a lot of it is not understanding the poor effectiveness of human fertility in general. So I like to step back and explain that but if they say, I want 3 or 4 kids, it's probably going to take every egg you can give me. But if they have 1, we might step back and take a conservative approach. And I'm more than happy to do that. I just tell them, it might cost you a little more in the long run, a little more time, but we can do that.
I love that. I mean, but yeah, I think that's one thing for anybody listening out there getting ready to go through IVF, especially if you have PCOS. I remember waking up and they said, you got 31 eggs. And I was like, oh my gosh.
People can do that.
What are we going to do with 31 eggs? But then the fall off just is so extreme. And it's almost like
the normal fall off of, I always say every follicle doesn't make an egg. And of the eggs you get, not all of them are mature. But of mature eggs, which is when I talk about like 15 eggs, I'm really talking mature eggs. Normal fertilization with great sperm is about 75%. So you lose 1/4 off the top. Mm-hmm. Growing them to the blastocyst stage, on a good day, you lose 50% of them again. So you go from 18 to 12 to 6, and depending on your age, maybe 3 to 4 euploid embryos, only 2/3 of them make a pregnancy. And so that's enough to make 2 pregnancies, maybe 3.
Right. Unless then you're getting them tested and then there's something there. So you can go from 20 eggs down to maybe 1 embryo.
And that's on a good day.
Yeah.
And some people bring quality. Some people can have quality issues with their eggs. And it might be less.
And that's one thing I try to talk to people about and prepare them for, because I think that that's a really big mental game, because you come out and you're like, yes, look at all this. And then when you're getting those reports and it's fall off, for you guys, it's very common. But for the patient, you're like, and then there are a lot of women that they'll take out 25 eggs and you don't even get 1 embryo. Yeah. And that's the reality.
A lot of them don't understand. That's why I think a lot of that is having the preemptive conversation heading into that of here's what I expect of you. A lot of that we have to wait and see how it happens, but this is what I think you'll do, but I want you to understand how this is going to go. And I think they are more prepared for that.
Well, I love that. I was going to say, I think that's, I felt like I knew a lot in the infertility world. And I think knowing that conservative approach is something that the clinic does is very interesting and really good, and really something that should be talked about and brought up more, because I don't think
all you got to do is ask.
I don't think a lot of people even realize it's an option. Like as somebody who's been in this space for a while, I would have loved to know a little bit more about that stuff.
And I honestly probably only have that conversation when people show hesitancies, because I try to understand them. And that's by far the number one hesitancy, I see is excess embryos. And, I tell them, I was like, I don't want to make embryos that nobody's going to use.
Right.
That's not my goal. I don't like that idea. I mean, I do have patients that discard embryos, and I don't like that, but it's their prerogative. Technically it's, property, but I don't like doing that. And so I want to hear the couple's story and where they stand and, what are their goals. And there are times that, you think things aren't going to go well, and she just does spectacularly well. And you're like, okay, you made 9 embryos. So there must've been something else. So yeah, you see those, but it's a minority of them.
But I even tell people too, I made spectacular embryos, and then we went through all of them.
Not every one of them.
Start again,
Yeah, not every one of them works.
Yeah, and even if it looks perfect on paper, it's not always a guarantee.
And some people, unfortunately, a lot of women, especially have never been pregnant, are naive to the miscarriage aspect. Of how big, and they unfortunately hits them like a brick wall when that happens.
That would be me to a T.
Yeah.
That's something I think when you go through IVF, you don't expect, because you're like, okay, I have every doctor looking at my uterus and my levels, and I have this perfect embryo.
And you hear the good stories.
Yep, and it's been tested, like, this can't go wrong, And I think that's a hard part for a lot of women, and a reality, and that was my reality, was, with Brexton, first transfer, perfect, easy pregnancy. So when we went into our second round, I thought, well, I'm going to document this for everybody to take away the stigma. There was not one little part of me, not even 1%, that thought I could miscarry.
Yeah.
Like, that just never crossed my mind, because I was like, well, literally, statistically, we are like so far ahead of the game. And then when it happened, it was
and that's
devastating.
That's my everyday. I always say my job, I love it. And it's because I'm giving even every day either the most wonderful news to a woman, or I'm about to crush her soul when I do that ultrasound. And it's hard for me, and I'll glance at it and I'll know within 2 seconds if it looks good. And when it's not, I have a sinking feeling in my chest, because I have to figure out what I'm about to say to her.
Is there one story over the years, I'm sure you've had to deliver that news a lot of times, but is there a story or a couple or a woman or something that sticks out to you still to this day?
Every one of them are hard. And, there are some that have, no idea that is a thing, that could happen. And there are others that go into it kind of more pessimistically. Mm-hmm. And that's why sometimes when you, especially doing ultrasounds, sometimes you can see that things look okay, but I have some concerns. And I try to share those concerns, because I tell people cautious optimism,
mm-hmm.
And so I always am not one to sugarcoat it. I don't want to say everything looks great, even though I'm concerned. And then next week I have to tell them bad news. So I try to, if it's something I can see and see it coming, I try to prepare them for it if that were to happen. But it is very difficult, of the ups and downs. And I usually know these patients pretty well by that time, and I'll roughly know how they're going to handle it, but it's rough,
mm-hmm.
And because I need to make sure of everything, absolutely sure. I want to make sure I'm telling them the absolute truth before I break that news to them. And I have 2.5 seconds to figure that out, and then how to pace it. And people just handle it so different. I've had some of the guys be wailing, just crying, wailing. It's so awful. And of course there's nothing I can say at that time.
Right.
And that's why I just stop, and we usually just sit there together for
mm-hmm.
20 seconds. And because I know nothing I say after that point is going to matter, there's times to have a discussion about things later, but that's not the time. And it's like any grief, that we want to say something. And I think sometimes it's better just to nod and hold their hand.
Yeah, I agree. It's hard. I remember when we went through our miscarriage, they made me come in, and the doctor went to see me, and we had Brexton with us, and I wanted Kyle in the room. And I will never forget, one of the doctors, he was getting ready to leave, and he had a fish tank in his office, and he took Brexton in to go look at the fish tank. Well, we did that, and that stuck with me so much, because he wasn't our doctor, and my son was clearly not his responsibility, but he was like, no, your husband needs to be in there with you, because it was like very obvious.
It scares me the most when people come and they bring their mom and their daughter and their 4-year-old and stuff. And I'm like, you don't know what could happen here.
Yeah, it was awful. Like, we didn't have a choice. It was so out of nowhere. It was in the morning. I started bleeding and then bleeding a lot, and there was nobody that we could leave him with, and I couldn't drive, and because it was a lot. And I will never forget, like, I think people don't realize that clinics, like, they go above and beyond, because there's sometimes that it's just like,
I've had a couple conscientious nurses when I have a child in the room, they'll be like, you know what, come, let's go get a sticker. Let's go get a sticker.
Let's go get, But I'll just never forget, because I was just preparing to leave Kyle and him together, and this doctor, like I said, he wasn't even our doctor, and he came through and he was like, nah, I got kids. I got a fish tank. He's staying in here. Your husband's going with you.
And it's kind of hard too, I think, for the women. Sometimes they'll come back for the second ultrasound. The first one was fine. They're like, I left the husband at home. And then she has to make a phone call and tell him.
Yeah.
Because, he wasn't there because everything was fine. He had to work today, And so that is one of the hardest parts of my job. I think to me, that's a hard part, but I think I struggle the more, and the ones that I literally lose sleep over are the ones that I can't get them pregnant. Those are the ones that hurt me to my soul.
Let's talk unexplained infertility, because I hate that term. I went from...
Well, it depends how hard you look.
Well, yeah. So for me, they were like, oh, in the beginning, it was like, you have PCOS and Kyle doesn't have a lot of sperm. And it went from like, that was your reason, and we're doing IVF. And then it was cycle after cycle after fail after fail. And then it was like, well, it's unexplained. And that to me is, and what I've talked to a lot of women about, one of the absolute hardest diagnoses, because you're like, no, explain it. Like, you have to explain it to me. You're the doctor. So like, let's dive into that, because I'm still a little bit confused by it, and I'm sure it happens a lot for you.
Yeah. Well, it's a large portion of what we see. The true definition of unexplained is, when sounds silly, but when you can't find an obvious issue. So a woman ovulates regularly. So PCOS is an issue, but if they ovulate regularly, the tubes look okay, and technically the sperm is okay. That's technically unexplained. I am a person, I'm kind of a mechanical fixer kind of guy. My love language is acts of charity kind of thing. And, I want to fix things. I fix everything around my house. I refuse to hire somebody.
I can do that.
I just finished patching the ceiling where my house was damaged in a hurricane. But I'm a fixer both in my own world and my medical world too. And I'm a problem solver. I've just been that kind of person. And so even if the patient doesn't want to know, I'd like to kind of know what we're dealing with to begin with, because that can affect maybe not what we do initially, but down the road, that'll rear its head. You'll come back and cross that. And so when they come in, have been trying for 3 years and everything looks okay, well, that's a big red flag. And those red flags fall into a couple categories, honestly, based on their age. Give me a 20-some-year-old, then there could be subtle tubal issues. Many people had been exposed to an infection. Chlamydia is the notorious one. One of the older classic studies in women and men who said, I've never had chlamydia in my life, 40% of us have been exposed to it and didn't know it. Huh. Well, we actually only diagnose a small fraction, and that's the number one cause of tubal damage. Unfortunately, today I had to give this news, did a dye test of the tubes and completely destroyed from a chlamydia infection in the past.
Wow.
But sometimes they don't, those x-ray tests, I always tell people they only show the tubes are destroyed. I have a lot of people come to me and say, my tubes look fine. And I say, no, your tubes just don't look horrible. There's a difference.
Right.
And sometimes you can have scar tissue around the ovary, but spare the tube, and it can look beautiful on an x-ray, but completely non-function. I can tell you stories after patients I've taken to surgery that were that way. And so sometimes subtle tubal issues can be part of the unexplained, particularly if they ever knowingly had a history of an infection like chlamydia. That risk is monumental. A lot of the symptoms in a younger population, if it's not subtle tubal issue, generally my number one issue is endometriosis. Mm-hmm. Almost all unexplained infertility in a young person who really truly cycles, endometriosis is it. So it's my biggest enemy of somebody that steps foot in my office.
So it's not unexplained. So that's just a blanket term.
Now, there are times you can have unexplained. Where we see that a lot of times is as you get a little older, in the 35 to 37 to 38-year-old range, a lot of unexplained starts to take a component of egg quality.
Okay.
And the hard problem is we don't have a test of quality. I have a test that tells me how many eggs you have there, an AMH level. That's one of the first things we get. But it doesn't tell me how good they are. I tell people my only marker of quality is your birth date. With a bell curve distribution around that. If you're I have women come in, I'm 40, but I'm healthy. I'm like, that's a sweet story, but unfortunately you're still 40.
Right.
You know, you still can be fine, but
yeah.
you're not 30. And well, what are the eggs? And we don't have a test of that. And so you do start to get into that issue in Unexplained as you get in the mid 30s. But a lot of reasons that a lot of people kind of discount it is just because a lot of, for a large portion of infertility treatments, we'll take a stepwise treatment. So they might do ovulation medicine, but that really only helps for the people who aren't ovulating. There's good recommendations if you're already cycling to not do that medicine. And unfortunately, I see a lot of patients who wasted a lot of time with their primary gynecologist or somebody. And I was like, oh, yeah, that was a year of wasted nothing, because it was not helpful whatsoever. And it's just because they're not educated to it. And I don't necessarily blame them, because they want to feel like they're doing something, but they're not. We know all they're doing is wasting their time. PCOS is a little bit different story, but a lot of people will do some empiric treatments, but then if you don't, then sometimes you have to pull out the big guns, which is like IVF. But I try to get an idea. I try to have at least an idea in my head and with the patient of what I really think it is. Do I think I'm dealing with an egg quality issue or an endo issue? We have tests to prove that. And at least I think for a lot of people, I've had women just come into me and, when they tell me their story and I'm like, oh, your symptoms are blatantly endometriosis. And I've had them just start crying and be like, nobody's listened to me.
Yeah. I heard endometriosis and PCOS are one of the undiagnosed things, because I don't know why, but it's almost like they have to fight to get listened to. Like, my period's hurt, and it's like, oh.
I mean, I'm very biased because of what I do, and I'm of course a sub expert, and to me, I can talk to a woman. Give me 4 minutes talking to her about her history, and I can tell you the majority of her problems, just by talking to her and listening to her. And but I also am from the view that I'm an expert. If I hear a ticking noise in my car engine, I might have a vague idea, but Kyle probably is going to have a better idea than I do.
But I kind of like that if I was going back to where I was when we were trying, instead of unexplained, I think that category should be more broadly defined as like, something's wrong, we're going to figure it out. But I feel like just saying unexplained gives women no hope. Right. I think that's the hardest part of that. Well,
and I tell them, I said, obviously something's not working, or we would not be here having this conversation. And that doesn't mean that it can't work. And even in these conversations, I'm like, I always have options. You don't always like my options, but I have options. Almost always there's options. And a lot of times, sometimes some of these steps are things that nobody envisioned. It's not, I mean, you were 22, you probably didn't envision absolutely didn't envision the course, and it's the lived experiences that take you down that road. And so I think, a lot of my goal is to hold their hands through it. And some people are ready to jump to the big steps faster than others. Other people need to take some more baby steps, for them, and if whatever works for them, handling it and handling the stress of it, I think is helpful.
Yeah, I think that's the thing that a lot of people going through infertility have to come to the mental terms with. I never thought that somebody else would be carrying our child. Yeah. And you have to get to that space where you are ready to do that. Yeah. So you might be able to offer that as an option, but it's really on that patient and that woman to feel comfortable and then be able to move forward.
And so sometimes those viewpoints, I literally just had this discussion before I came over here today, is that, sometimes those perspectives will change. I had a discussion about using donor eggs. That was an only choice. And she's like, we're not, going to do that. I'm like, well, but sometimes a couple of years, a person will come back and say, they have to ask themselves which is worse.
Yeah.
And that's hard. And I don't expect them to give me an answer right then and there. I'm like, you just need to process this. And I think too, it's very hard on the guy side, of the psychological aspect, because guys aren't usually sharers. We want to make our wives happy, and we want to do whatever and I think they do suffer in silence for a lot of this.
I see that a lot.
We have to put the face on to be the strong one in the family sometimes, most of the time. And, I can't imagine going through the miscarriage aspects. I mean, I see it every day. I've not experienced that myself, but trying to be the strong person for her.
I love that we're having this conversation, because I would love if women shared this podcast with their husbands, because just like reading the Bundle of Joy Fund applications, I feel like those men a lot of times are looking for that outlet of somebody to kind of hear their story and how hard it is on them to watch their wives go through it. And as you said, not be able to fix it. Or a lot of men that we have that it's male factor. So their wives, everything's testing out fine, and it's them. They carry that burden.
That can be hard. And everybody, of course, handles it different. But I know for so many of them, and it's not that it's an ego issue, but I think it's not much different when I had my guy this morning that was born with no sperm, to tell another woman, she needs donor eggs. And, guys, we often didn't understand, but we thought, hey, I want to have kids. I want to have a son to carry on my name or whatever. And then, to be told that, I think it's a real heartbreak, and they often don't share it. And I know that's tough to carry that around. And, but I think the same things, it's a couple's disease.
Mm-hmm.
I tell people, infertility is not a male or female. It's a couple's.
Right.
Even if I think you're great and it's totally him, it's still a couple's disease.
100%. Though I will say, because Kyle and I both had issues, it almost made me feel better.
There's always a little bit of both.
Well, at first though, because my OBGYN, they finally, they figured out after a good year plus I had PCOS, they put me right on Clomid. They never bothered to test him. And it wasn't until we got to the fertility clinic after 5 rounds of Clomid, which was awful. That drug needs a huge warning label on it. You will be a crazy person, it should say, across the box. But when we found out that he was the issue too, it did, at least for me, take that, oh, okay, it's not just me. So I could see how if it's only one person in the couple, it is hard. You do feel guilty,
And I sometimes see people come in that place blame on a partner too.
Oh.
I can't tell you how many times I've had the guy and the woman doesn't even want to come in. She's like, it's not my problem. I'm like, oh, honey.
Oh.
Yeah, it's not how it works. And then I talk to her and I'm like, red flag, red flag, red flag. She's got all this stuff that she didn't know about. Or it's the guy, the otherwise.
Yeah.
It's not, I'm very quick to put a guy in a spot. If a guy comes in and I have a lot of guys, I don't want to do a semen analysis. I'm like, oh, okay, listen, I will put a guy in a spot. And a lot of times it's a woman to be like, I've tried. And I always tell the women, we need a semen analysis. And I'm like, don't tell him to call and schedule it because he's not going to do it.
Right.
I wouldn't do it. I'm like, you tell him when he's going to do it and you call and schedule it. But yeah, I have no problem putting a guy in his place and cutting his ego down a little bit.
It's so funny. At some of my meet and greets, people come in as couples. And I literally will tell them together, I'm like, you need to get your sperm checked. And he's like, this is not what I was standing in line.
Absolutely the first thing to do. Absolutely. Because it's a guy, I like the guy side because it's way more black and white.
Right.
The female, I don't know what's happening inside. And everything I'm looking for on a woman is looking for bad red flags. But just because you don't find a red flag doesn't mean everything is okay. The guy is way more black and white. And I tell them, I'm like, look, suck it up and do your thing. If you're fine, we're done with you.
Right.
Then I will focus on her. But so many times, we'll do that and then find out, there's an issue and that shifts everything. Then none of her stuff matters as much until we figure your story out. And sometimes I can help the guys, sometimes I can't. But there's, options to work around that.
Well, I love that. Preach it louder. Everybody needs to get everything tested, not just one or the other.
And the guys it's the easiest, simplest, cheapest part of the workup too. It's
really not that hard.
Yeah. I was like, I tell the guys.
This is way more fun than ours.
I say, you've been practicing for 20 years. You can do this. I've got faith in you. And of course, you wouldn't believe how many guys say, oh, I don't do that. Yeah, you lie too. Okay. You're a liar. There's the guys that lie and the ones that have done it. So
I want to just know how many sit in there for an extra 10 minutes before they come out, just so it didn't look too fast. That's what I was thinking.
Just today, I asked my lab girl, I was needing to talk to the guy afterwards. I was like, how long has he been in there? She said 5 minutes. I was like, give him another 30 seconds.
Yeah.
And there are some guys that walk out of there surprising, she didn't even get back to her desk. There's some guys that are 3 minutes out. But we've had some guys that get stressed in a weird place that are in there an hour or more. And we've literally had to tell some guys, maybe you need to call it a day and come back another day. Yeah, we've had, because we was like, this is a room, we need it. We've had guys be over an hour. We're like, okay, bud, it's not working.
What are you doing in there?
It's not working. We're just going to try another day. Okay, you can do it. We got faith in you, just not today. We need to clean the room. Other people coming.
We need to get some more materials in. Give us what you like.
Yeah, I will go shop for that. Yeah. See, these are these behind the scene things when who has to go buy the magazines? Travis does it.
I never actually thought about that at the fertility clinic. Who has to go get all that?
Yeah, I had to make an eBay order of some things, but magazines don't exist so much anymore. So most people, I guess, are using their phone.
I was going to say, I feel like
we have a DVD player, but
a DVD player.
A couple years ago, I refreshed the magazines and there were literally some from 92. It was really throwback.
I feel like people should just bring their phones at that point.
Yeah, and in the old days, my offices, we just would have a subscription to Playboy, and but now it's gone away, so you can't get it. And
Playboy went away?
Well, in print form mostly, yeah. Yeah.
Well, I mean, that's crazy because guys were just reading it for the articles. So,
Of course. Yeah. But we just used to get it so we'd always renew it. Well, because people would steal your magazines too.
oh, I was going to say, they took
Every
those
guy. And I'm
Playboys
like,
home.
do you know how many guys have touched that magazine?
Ew.
But guys don't care. But yeah,
Ugh.
but they would walk out the door, and we've had DVDs and everything walk out the door. And so it's, yeah.
All right. We're going to wrap this up. So have you ever played like the hot takes game?
No.
Okay. So I'm going to ask you something and you're just going to give me like a quick on the spot answer and then like a short reason why. Okay.
Yep.
So we're going to do hot takes.
Have at it.
Birth control, miracle tool or root cause Band-Aid?
Best thing a young woman can ever do to help preserve her fertility in the future. For so many different reasons, it helps regulate the hormones, especially PCOS. It's a mainstay backbone of PCOS treatment. So it's always going to help her down the road for many reasons.
Really? I know this is a hot take. I have to interrupt. I was put on it at 14 or 15. I felt like it was just like a blanket that covered everything and I never knew. And like now I'm almost 40 and I still can't have a menstrual cycle normally.
Well, and a short hot take.
Sorry.
The issue with PCOS is, the brain is not sending proper signals to the ovaries to make you ovulate. And so when you don't have adequate levels of estrogen. And there are some women with PCOS that are in the more overweight, obese category, and they run risk of developing overgrowth of the lining of the uterus. Mm-hmm. And so a birth control pill I can't tell you how many times I diagnosed pre-cancer in a PCOS patient every month. And being on a pill would have just prevented that. But the extra problem is having excess male hormones. And that is what makes the not ovulating even worse. So that greatly suppresses those. So pill, the absolutely best thing, a woman can do in any situation, but particularly PCOS, it's the mainstay treatment.
Personal question. Should you stay on the pill if you're not, like at this point in life, like clearly?
Anytime you're not getting pregnant, it's really the best thing to do. Now, as you get into a little bit of blurry range when you get in the mid to upper 40s, you start to run into things, but a birth control pill can be used successfully, all the way up until menopause in an otherwise healthy woman. There's some women may have some contraindications that shouldn't use that, but the not cycling, there's different forms of PCOS and the way they behave. But the not cycling is not real great to do long term.
Interesting. Okay. This one will really be a hot take. PCOS or endometriosis, which is trickier to treat?
Endo.
Because?
Endo can be managed. Endo is an environmental issue. It makes a toxic environment that is basically toxic to the eggs and the sperm. So from a fertility standpoint, aside from pain, surgical treatment can help that some, but I can never restore her back to as good as it should have been. It can make her a little bit better, but I can't get her even close back to baseline. And so that's why surgery is not always the fix-all for all endometriosis cases, because to appreciate the benefits of the surgery, they got to be willing to try another year and a half. Long time.
It's a long time.
It definitely helps them, but it's not for everybody. But PCOS, I tell people with PCOS, those girls are either easy to get pregnant or very difficult. And you don't know till you start trying.
Sometimes
doing ovulation medicine. But I have some people that we can ovulate them over and over and over, and they not get pregnant, and they do IVF, and they're making beautiful embryos. But some of those can have some egg quality issues with them too. So it's either real easy or real hard, and that's why most pregnancies are going to be in the 4 to 6 months with PCOS, or it's not usually going to happen.
Interesting. Embryo ranking, helpful science or false sense of control?
Ranking as in?
Well, like, when you get tested.
Like the grades?
Yes,
and stuff?
all those grades.
Genetics trump everything. We have large data sets that, we grade them morphologically, looking at the inside cells and the outside cells, how pretty they are. We use a lettering scale, A, B, C, D.
Yeah.
And, the A's and B's, what we see that the A's and B's are absolutely identically equivalent. C's, which is the limit of ones that are still alive, you start to see a decrement of success. So if I have a genetically tested normal one, A's and B's don't matter. They do identical.
Okay.
You see a little bit lower chance of success in the C's. So I kind of tend to put the C's like a BC or a CB. I put them a little bit lower. And CC is way lower, but tons of beautiful babies from even CC embryos, that are genetically normal. But the A's and B's are absolutely equivalent. So people say, which one are better? Those are all the same.
Okay. I think we touched on this a little bit, but supplements, useful or just expensive?
It depends, in a situation, it's like I said, the biggest thing is eliminating the toxic things. Supplements, the only ones that really have true any human data. There's none that have good human data to show it improves. A lot of guys get put on vitamins. There's actually not a single study that showed an improved pregnancy rate with male vitamins. Some have showed questionably improved sperm, but based on really flawed studies, none of them have showed improved pregnancy rates. No supplement in a human has showed improved pregnancy rates, be it in IVF or naturally. So no supplements. The only ones that have theory, you'll hear about CoQ10. Theory, not a lick of human evidence to support that it makes anything any better.
Really?
But at least it has some theory. Some people have, you hear about DHEA.
Yeah.
DHEA can actually have some harm in some patients if the wrong patients take it. Some PCOS patients make too many androgens, and DHEA can actually be harmful to them. And it's only helpful in a subset of people that might have really low ovary function. And even there, some of the data is controversial on that.
Wow.
So, so I tell people, just be healthy. That's the main thing. Figure out what works for you to handle the stress. Whatever your stress reliever is.
Yes.
Because I think that helps a person.
I think stress plays a very big role in infertility.
Yeah, I mean, it does. It's hard to quantify.
Yeah.
It's hard to study. And that's what I tell people with IVF. I say IVF, honestly, it's not that physically hard, but it's terribly stressful.
Mm-hmm.
The people who you can tell by stress, because most people in a fertility world didn't want to be there. So the people, if you ask the women who are doing like egg freezing, like being proactive and freezing their eggs, they will tell you it wasn't really anything. They handle it like a trooper because they're being just proactive about it.
Right. Versus this is like their only option to have a child.
And so many of those people, I tell them too, when you've gone through these treatments, you got to save a little bit for IVF. You don't want to exhaust your whole mental capability before you get there, so you got to be careful not to completely burn yourself out before you get into IVF, because sure, it's going to be stressful and take a little bit of time.
100%. Well, I will say, as somebody who thought they knew a lot of stuff, I learned a lot talking to you today.
We got hours more stuff to talk about.
I know. But I feel like there's things that I was like, I had no idea. And again, I think that's where you say, like, the internet's great, but there's also a lot of misinformation out there.
I could talk an hour just on the male side.
Right?
Or in the endometriosis side, yeah.
Well, I thank you so much for coming out. We will definitely bring you on again because that was fascinating. And I think a lot of people listening that are getting ready, to go through IUI or IVF, like this is a lot of good knowledge that I don't think, there's a lot of knowledge out there. Yeah. But I think especially as you
overwhelming.
Hit on the male side, like there's a lot of, I don't want to say easy steps because nothing about IVF or infertility is easy, but like both of you guys get tested. Like I think that's a really big take home from today.
And I love what I do because I can see both sides, because it's not just fixing the male side. Everything I do with the male revolves around her situation. Everything with her situation revolves around his situation. Right. And so I love being able to bring the both of them together.
Well, perfect. Well, thank you so much for your time.
Thank
this is
you
a great
so much,
conversation.
Samantha. I really appreciate you having me.
Thank you.
Thanks.
Wow, I found that conversation super fascinating. I really wish that there were some things that I had known when I was going through infertility. Like, for example, if you want to take a more conservative approach, no, to start in the beginning, you can't take one egg at a time, but you can have that conversation with your doctor that you want to try not to have an excess of embryos. I also think it's so important, if any of you guys out there are listening, that your husbands are just not wanting to get tested, please have them listen to Dr. McCoy. I think it's so important to understand that this is not just a female issue. So again, thanks for listening. If you guys want to make sure that you don't miss any of our episodes coming out, be sure to subscribe on YouTube and follow along on all social medias at Cert Oversharer. And if you would, please take 2 seconds to drop a comment. That way, give us a good review, more women can hear us, and we can all overshare together.